Hi, my name's Rick Walker. I'm the clinical lead for the Queensland Youth Cancer Service, and I'm going to talk to you about using big data to inform the management of AYA cancer in Queensland. So as my previous presenters have said, in Queensland we're in a unique position with Cancer Alliance Queensland and their oncology repository, which is the largest of its kind in Australia. This centralised repository holds information from over 60 data systems and cancer care providers across Queensland, and it also provides comprehensive high-quality data that helps clinicians, policymakers and researchers to improve the performance of their cancer services. Queensland Youth Cancer Service hoping to improve the service towards all AYAs within Queensland, and so we collaborated with CAQ under the direction of the Youth Cancer Subcommittee. And the Youth Cancer Subcommittee is a team of clinicians which have an interest in adolescent oncology, providing clinical guidance and leadership, and I'm the chair of that committee. We published some reports through CAQ, and these can be found on the website, and we use these to review our service and work out where we can actually make some improvements. One of the main things is we saw that over time cancer incidence has decreased by almost 20%. A lot of that is due to the fact that melanoma is probably the largest contributor to AYA cancers in Queensland, and it also has an excellent cure rate, but some of that improvement in survival has been attributed to public health campaigns such as the Slip Slop Slap. When we look at the most common AYA cancers by sex, we can see that some of them are essentially 50-50, but some are more skewed towards males. So males are far more likely to have germ cell tumours than females, whereas thyroid cancers are far more likely to be in females than males. And I would just note that we've put a box around the melanomas, thyroid cancers and appendix tumours, as they often require treatment that doesn't involve systemic therapy or radiation and may just involve surveillance and or surgery. In fact, 90% of those group will only require just a simple procedure, and only 10% of them would actually require some form of treatment, being that in the form of radiation therapy or chemotherapy. As such, we essentially removed that group of cancers from the overall data, but in the 5-year survival, it was still in for this, and we showed that from the 2008 to 2012 versus 2013 to 2017, the overall survival was excellent in 5 years, and it remained excellent over the 10 years. It probably does mask it's probably masked a little bit by the fact that melanomas, lymphomas and germ cell tumours are some of the most common tumours, and they're also the most curable, and so it can actually hide some of the poorer performing cancers such as brain and CNS tumours or some of the sarcomas. But in comparison to the USA and the UK, we're certainly comparable, and we may have just slightly increased due to the increase in melanoma and the survivability of that. From 2014 to 2018, we had a look at the diagnoses, and of those, 36%, or just over a third, were presented to a multidisciplinary team meeting. And when we look at the MDTs, that's also using the COOL database, which is part of the Cancer Alliance Queensland, and most of the public hospitals are using COOL. Some of the private hospitals are not, and so therefore those numbers would not be included in these numbers. But when we look at the overall number of patients, with 36 presented to the MDT, if I just look at the ones that are less likely to be presented, would be the ones that are the most affluent, the ones that are in the older age group, the ones that have no comorbidities, or if they don't have a dedicated AYA care coordinator, and if they are remote. The other thing, when we look at cancer types itself, the ones that are less likely to be presented at MDT are the germ cell tumours, whereas bone sarcomas are more likely to be, and that's really to do with a reflection of the type of treatment that they might need, with a large number of germ cells only needing an orchidectomy, and whereas bone sarcomas often require multimodal treatment. When we look at treatment notes, we did exclude the appendix, melanoma and thyroid cancers, and over the 2014 to 2018 there were 705 AYAs diagnosed with cancer without those three, and 48% of them received surgery, 60% received intravenous systemic therapy, 27% received radiation therapy, and 10% of patients received surveillance only. When there's higher surgical rates in particular types of cancers, are the ones that you would expect. Orchidectomies in the germ cell cancers, the brain and CNS tumours are more likely to have surgery, and bone sarcoma is also more likely to have surgery. When you look at the hematological cancers, as well as some of the sarcomas, they're more likely to have the intravenous therapy, and the radiation therapy is more likely in the CNS tumours or the lymphomas. With the Cancer Council AYA guidelines, it says that we should get GPs familiar with the common AYA cancers and encourage urgent referral to an oncologist. With the fertility preservation, the options should be discussed for all AYA patients, and that the cancer treatment team should work with the fertility specialists. And when you look at pregnancy after cancer therapy, it should be managed as a high-risk pregnancy. In the guidelines regarding psychosocial management, it recommends effective AYA communication and supporting the AYA relationships. There are the physical and medical issues such as alcohol and drug use, and the impact on sexuality, physical appearance and function, and as well as the impact on their the psychological well-being. With fertility preservation, 64% of males had fertility preservation and 59% of females had fertility preservation. And you can see from this graph here that the soft tissue sarcomas and bone sarcomas were the most likely to have fertility preservation, and the leukemias were the least likely. And when we look at who is more likely to have fertility preservation, it is the younger age group, non-Indigenous, if they're in the public health system, if they have less than 2 comorbidities, and if they are remote. I would note that if they're remote, they're more likely to be treated in a major metropolitan centre, and so therefore that's why it's reflected in the fertility preservation. In terms of why a male is more likely to have fertility preservation, it can come down to it being an easier process, and it may come down to also the types of cancers that they have. When we shift to the last guideline in the Cancer Council for the psychosocial management, we did an overall review of who had psychosocial management, and you can see that in certain cancers, if there was an AYA care coordinator, they were very likely to be referred to for psychosocial assessment and have psychosocial management. than in some of the others, such as germ cell tumour, and again that can be a reflection on the fact that a lot of the germ cell cancers can be dealt with surgery only. So some of the psychosocial management is considered a low need. The idea of having psychosocial management is to not only minimise the short-term and impact, but also the long-term impact on these young people with cancer. And the Queensland Youth Cancer Service has 5 partner hospitals: Royal Brisbane, Princess Alexandra, Gold Coast, Townsville, and the Queensland Children's Hospital. And at each of these sites there is a AYA care coordinator that's dedicated to assisting these young people. When we look at who's the most likely to have the psychosocial management, if you are younger, so at the children's, you're more likely to be treated at the children's hospital than in an adult hospital, and therefore more likely to have psychosocial management. If you have disadvantage, then you're more likely to have psychosocial management. If you have if you have any comorbidities, and if you are remote. This slide brings back to the fact that the type of cancer that you have and the type of treatment can also impact whether there is a perceived need for psychosocial management. And if you have surgery alone, then a lot of the patients don't actually feel that they've even had cancer, or it's something that's been dealt with, and so they're less likely to have psychosocial management. When we look at the public sector versus the private sector, people are more likely to not only have more psychosocial management in the public sector, but they're also more likely to have multiple people involved in their care. So how did all this data inform the AYA review? Well, we need to ensure that every AYA is seen in a partner HHS and is referred to their Youth Cancer Service team. If they're not, then they could be referred to the statewide Youth Cancer Care Coordinator. We're to encourage active GP engagement and if they don't already have a GP, make sure that the AYAs get a GP so we can maintain links both during their cancer journey, and as you've seen, they have a very high survival rate, so it's also a lot of care post-cancer. And that leads into then the survivorship care planning, and we need to also look at how we increase the access to the Queensland Youth Cancer Service services for patients not seen in partner sites, and aim to do that through increasing our partnership with the community services, promoting awareness of the Queensland Youth Cancer Service, increasing the AYA self-referral and clinician referral, and ongoing monitoring using the COOL database and COOL Dash. With the ongoing monitoring, that can all be done through these databases that are set up through the Cancer Alliance Queensland, and it's a web-based technology which was used by 70 MDTs across Queensland, and I'm hoping to continue the use of these to continue to improve the advancement in youth cancer care for the AYAs. Thank you very much, and we'd like to hear from any of you, and if you have any questions about Cancer Alliance Queensland or the Queensland Youth Cancer Service, feel free to